Hi, my name is Alexander Gutierrez, and my preceptorship took place in Bremerton at Harrison Medical Center in the intensive care unit.
Hi, my name is Zhao, and my preceptorship is at St. Joseph Medical Center, the seventh floor, Med-Surg Tele.
So, what got us interested in this topic? My personal reasoning was that I was seeing a lot of admitting diagnoses in the H&Ps as sepsis, and seeing that I would probably get more patients having sepsis in the future, I thought this would be a great idea for my capstone project, just so I can be sure that we are caught up on sepsis care, especially in older adults, since that's the population I would see mostly coming in with those sepsis diagnoses.
So my interest was similar to Alex. On my floor, that I've taken care of a lot of sepsis patient, or who had sepsis before, or who are going through some kind of infection. And also, our care manager and charge nurse really focus on reminding the staffs and nurses to have good hand hygiene, to know a lot about infection prevention. So that got my interest into sepsis as well.
So, reading the articles, we did find a lot of literature on sepsis, which was great for our, initial research. But what we didn't find was things such as post-sepsis syndrome or post-intensive care syndrome. We had to do a lot of digging for that, and that was surprising, especially since a sepsis diagnosis costs Medicare over $14 billion a year. And we're seeing that trend of admitting diagnoses of sepsis going up and up, all the way back from 2012 up to now.
Yes. So what surprised me during the literature review is after we look more into the pathophysiology, that we have realized that how vulnerable our elderly population is. And we noticed the importance actually for nurses to practice patient care, patient educations on the infection prevention and patient education about what kind of signs and symptoms considered a red flag and that need to be required immediately medical treatment. Also, as Alex mentioned before, that the literature we've looked through had a lot about ICU cares, about sepsis and med-surg cares, but however, there wasn't enough about transitioning the care. For example, like transitioning how to transition sepsis patient from ICU to med-surg, or even from med-surg to home care. So that's what surprised us.
And so, some of the big takeaways that we want our audience to take away from this presentation, this poster, is obviously that with sepsis, we're going to definitely have a focus on resuscitating that patient out of sepsis, especially in the elderly population, since they tend to see a decrease in survival rate, especially with the diagnosis of sepsis. But we have to remember that this care does not stop once the patient is resuscitated. We're going to continue caring for them outside of the intensive care unit, up to the med surg units, and potentially even in a long-term facility.
Yes. So we have realized that sepsis survival does not really equal to a good quality life or even a good independence level. So for nurses, when it comes to nursing interventions, we really want to focus on arranging the PT and OT. Um, Encouraging the patient to improve their ADL levels and to make them independent, and as well as assessing for post ICU care syndromes and post sepsis syndrome for any cognitive changes and mental changes. So, also assessing for emotional needs and psychosocial health and providing the cultural and spiritual needs when they need it, as well as connecting the patient and patient family to the right resources, such as the social workers, or local community resource, or even a palliative care team or long-term facilities.
Yeah, and just going off of that, especially in the actual transition of being in the ICU to the medical surgical floor, it's kind of a culture shock to the patient and the patient's family, because you're switching from this 24-hour around the clock monitoring to a less intensive unit where the patient might not feel like they are receiving as good a quality of care, even though their condition is better and they need other things such as, physical therapy and occupational therapy, as Sen has mentioned, as well as keeping that family included in the conversation, not just treating them like a visitor. They're still family to that patient, and as long as the patient consents, they should be aware of what's going on. Now, in terms of questions that we had experienced, one of which was asking about how nutrition is an indicator of how elderly patients are doing in the hospital setting. And this is true, especially during the initial resuscitation from sepsis. And what we want to push is that um, electrolyte and micronutrient repletion. Now, that is suggested in terms of sepsis based on patient needs, but the literature does say that elderly patients are going to be lacking in the necessary electrolytes and micronutrients. And so it'd be pretty important for us to be pushing those types of things to make sure that our elderly patients are doing well all around. And Sen has already talked about infection control, but we really want to emphasize this because something like a pressure ulcer is really going to affect the outcome of that elderly patient, whether they survive sepsis or not, potentially. And so pushing for those Q2 hour, turns and doing those frequent skin checks are very important to the outcome of the elderly patients, especially since they already have impaired skin integrity and potentially a compromised immune system. So just being aware of that. And
So at the end, we want to give a special thanks to Dr. Megan Morrison for her thoughtful input and her knowledge and feedbacks. And we also want to thanks for both our preceptors, Kimberly Osh and Miriam Campbell, and the rest of the Harrison Medical Center ICU staff and the St. Joseph Medical Center staff for their encouragement and support. Thank you very much.
thank you.